Thank you. Happy to introduce the next session, which is very dear to my heart, and that's primary staging. There's been a lot of action with new molecules, PSMA, but the thing is, should we stay with bone scan, yes or no? So I'm very happy to introduce, first of all, the panel. Henrik, as a medical oncologist, Henrik Grönberg from Sweden, Stockholm, who has been involved in many trials, great leader in how to set up trials. He will be the medical oncologist representative tonight, joined by, of course, a urologist, Walter, who will be looking with his surgery perspective, and me, of course, as a radiation oncologist. As a first speaker, I'm happy to invite Anwar Padani, who, of course, is very well known. He's done a lot of work with PIRATs, for example, really establishing and changing how we manage the first diagnosis of patients with prostate cancer. And also for radiation oncologists, the PIRAT system has improved us enormously in learning how to interpret the MRI. And he's going to teach us how we probably should not yet throw away bone scans and CT scans or CT scans. Anwar, floor is yours. Oh yeah, there's a question, of course, that I'm happy to introduce. If we can get the next, is it clicking or? Yeah, I'm clicking left. I can click right. No. Okay, so the first question is one of you, right, Anwar? Should next generation imaging actually replace bone scan and CT scan in the clinical assessment of men with locally advanced prostate cancer? So this is an enormous amount of patients we have. So if you would change from one to another, I think nuclear medicine departments need to expand enormously as well. So please vote. And this will spur up the discussion. And we will have this question again at the end to see if your opinions change. Because the second speaker we will introduce afterwards will defend the PSMA as the one-stop shop. It's good. Something where you can work with, right? Floor is yours.
Yes, thank you. All of you like pretty pictures, don't you? Okay. Well, I'll show you that it's actually quite dangerous to like pretty pictures. Let's see if I can go forward.
I right-clicked.
Left click, okay. There we go. Okay, so my remit today is to talk to you about why you shouldn't throw out bone scans and CT scans today. These are my disclosures, and you can see it's all imaging companies, so no drug companies here. Okay, so what I'm going to try to do over the next few minutes is to place bone scans and CT scans as the centerpiece of how you should direct the care of your patients, while I will acknowledge that there are issues with bone scans and CT scans. And in that way, I hope to be able to frame the use of next generation imaging technologies such as PSMA PET CT or whole body MRI as a problem solver that follows the bone scan and the CT scans, because of the confusion that is caused by PSMA PET CT amongst you, not amongst me. I'm going to focus on why we should continue to use bone scans and CT scans, because there is level 1 evidence, very high levels of evidence of management impacts because of the prognostic and predictive value, particularly for pelvic radiotherapy, for example. And then I'm going to challenge Daniela, who is going to, about providing really high quality and level 1 data so that you guys can then think about how you might change your imaging paradigms. So we're really talking about the area in pink today. So you know that this is the prostate cancer disease states model, and the pink area shows high-risk localized and high-risk locally advanced disease, which may or may not have synchronous metastases, which may be oligometastatic or polymetastatic. And one thing you'll know or be able to see is that PSMA PET CT does not exist. So as far as the disease state model is concerned, it does not exist. Therefore, you shouldn't be using it. Now, clearly, we are in transition. So in 2022, you can see the modalities that we use to decide who gets what treatment. And of course, in the future, it'll change. And we are now going through this transition period, and you can see how PSMA PET is justified to the right and not justified to the left. And that's to try to indicate that change that needs to occur as we go forwards. So the first and the most important thing is the prognostic value of bone scans and CT scans. So if you look at this data, quite old data, that all of you are aware of. So if you have nodal disease, you're going to live longer than if you've got visceral metastases, and if you've got more than one site of disease, then you're going to live less than if you have a single site of disease. And this isn't a surprise. But what this shows is the volume and distribution on a bone scan and a CT scan, or a shitty scan, or a bone scan bullshit scan, is in fact prognostic. And in fact, it is now in the risk stratification. Now, all of you've seen the risk stratification systems, such as latitude, charted, and more latterly, the Stampede definition. So if you look at the Stampede definition and look at the prognostic value for abiraterone therapy. Now you can see here that the distribution, the volume of bone disease on a bone scan is in fact prognostic for the success for abiraterone, and obviously people with lower volumes of disease do better than higher volumes of disease, but you can see both groups in fact benefit from the use of abiraterone, and in fact you find similar things happening with docetaxel. In other words, this is generalizable. And in fact, it turns out that bone scans and CT scans are independently prognostic. So they're independently prognostic of nodal status, of Gleason score, or even the performance status. So these are very powerful prognostic tools. Let's talk about the predictive role of bone scans and CT scans in the metastatic setting regarding pelvic radiotherapy. All of you will also have seen these data. These data show that if you have a smaller volume of disease, that you benefit from pelvic radiotherapy in the setting of metastatic castration, in the setting of metastatic hormone-sensitive prostate cancer, whereas if you have higher volumes of disease, you don't, right? This is level 1 evidence for the predictive value. And again, you see here that it's predictive of regardless of performance status, Gleason score, tumor stage, etc. Okay, so it's very, very predictive. And that's why Pete and others in this group said that patients with high risk and high risk locally advanced prostate cancer should be staged primarily bone scans and CT scans, because there's a very high level of evidence for this, and that you should not deny patients with pelvic radiotherapy if you saw metastatic disease that was polymetastatic in using just a PSMA PET CT scans. And in fact, this is also confirmed by the ASCO guidelines. So the ASCO guidelines say essentially the same thing. In newly diagnosed high-risk, localized, and high-risk locally advanced disease, when conventional imaging is negative or suspicious, in other words, do conventional imaging first, if your clinical suspicion is high or it's equivocal, then you can think about using next-generation imaging if it would alter your therapy plan. Now, clearly, we know that therapy plans do change according to whether you have metastatic disease or not. And so, for example, if you look at a patient who seems to have, let me show you a patient who seems to have M0 disease, just to illustrate this issue. So look at this man here. So he's got a locally advanced prostate cancer, and this is on the digital rectal examination as well as on the MRI. This is a T3A tumor, and you can see that this is a Gleason 9 tumor with a very low PSA. So clearly quite poor risk. So he had a bone scan and a CT scan. So you see how you've got two lesions on a bone scan with a non-concordant abnormality on the CT scan. So what are you going to do? Does he have bone metastases? Maybe, maybe not, right? Is this oligometastatic disease? In other words, less than 3 to 5 deposits? Maybe, maybe not. Okay? So in terms of a therapy plan, should he have prostate radiotherapy? Yes, definitely, right? There's no doubt about that because he's got locally advanced disease. But how much adjuvant treatment are you going to give afterwards? Is it going to be just the standard 2 years? Or, because this is metastatic, should it be longer? Because you're going to be thinking about stopping the adjuvant ADT after some time. Problem, you see. Do you really want to know what's going on? And all of you are going to go like this, yes, please. And of course, he has a PSMA PET CT and he has a whole body MRI. And when you look at the spinning image on the right, and Daniela makes these lovely images that have convinced you with that first poll that you saw, you can see that they look great. They're fantastic. And you know what? That lesion in the right acetabular roof is a metastatic deposit because it's confirmed on a PSMA PET CT and it's confirmed on the CT on the whole body MRI scan. But remember, it's negative on the CT scan. So it's an intramedullary deposit. Ditto for the left 7th rib. Okay, so here we are. So we had 2 or 3 lesions on the bone scan, nothing on the CT scan, 10 lesions on whole body MRI, 10 lesions on the PSMA PET CT. So is this all the disease that he's got? Is this the true burden of disease? It subtends towards the truth, but it's not, you see. So does this provide clarity on what you should do in terms of a management plan? Should you treat pelvic radiotherapy with pelvic radiotherapy? Yes, I don't think anybody would doubt about that. But what are we going to do about androgen deprivation afterwards? Okay, now that you know there's 10 deposits, are you going to stop after 2 years of ADT? Or are you going to say, well, actually, he's got polymetastatic disease, I'm going to give him lifelong abiraterone? You see, these are questions that come up and lead to confusion. And in fact, even the biggest experts in the world are confused. If you ask them to make a decision on the basis of a bone scan and a CT scan, 99% of times, and that 1% was probably me, they said, I know what to do. You add in a PSMA PET CT in that mixture, and everybody's going, oh, I don't know what to do. So if the experts are confused, what about you guys? Right? What are you going to do? Is there level 1 evidence driving your decisions? And remember, not all PSA is the same, right? So let's take a PSA that isn't the same. Okay, so I showed you gallium PSMA, now I'm going to show you fluorine PSMA. Okay, so here's somebody I know personally, T3 disease, microscopic, 4+3 on a targeted biopsy, a negative bone scan. So he has a PSMA PET CT, and we see 3 lesions. Okay, now 2 are in the ribs, and we know that there are false positives on a rib. Okay, Daniela will tell you that, I'm sure. But what about that lesion in the right iliac bone? Well, that's got an SUV of 7.6. That looks like a metastasis, but on the MRI, it's negative. Now what are you going to do? Because this is a discordant abnormality between 2 next-generation imaging technologies. What are you going to do? Again, this speaks to that confusion between gallium and fluorine. So not all PSMAs are the same in real life. Okay, so then you read the ProPSA study. The ProPSA study comes out with this statistic, that 28% of patients had a management change after doing the PSMA PET CT. 28%, 1 in 4. But if you look at the regulatory submission for PYL PSMA, a different type of PSMA, so a third different type of PSMA, it says very clearly in the regulatory submission whether this will have an impact on survival or other outcomes remains to be determined. In other words, there's no overall survival, progression-free survival. There's none of that level 1 evidence that you guys need to treat your patients. And in fact, this has been pointed out in numerous publications. Are we treating images or are we treating patients? Very important question. Very important debate. And in fact, the JCO article, the one on the right-hand side in the middle, says the value of imaging comes when you show that next-generation imaging maximizes a benefit, minimizes undertreatments, prevents overtreatments, while tempering costs. Okay. After biases are taken into consideration. Okay, biases. What are these biases? There are loads of biases. When you detect disease earlier, the Will Rogers effect or stage migration bias is a really big factor. And then you also get lead time bias. And because you detect indolent disease or relatively indolent disease because you have a more sensitive technique, you end up with length time bias. So in fact, you end up with lead time bias, length time bias, and stage migration bias. So you need to control for all of these to be sure that a next generation imaging technology is in fact giving you actual survival benefits. Is there data to support this? The answer is no. Lastly, I'd like to talk to you very briefly about the central role of bone scans and CT scans in drug development. And clearly all of you are using drugs. Okay. Now we know that the M0 state as defined by bone scans and CT scans identifies certain disease states. And these disease states are ripe for drug development. So for example, high-risk biochemical recurrence, high-risk non-metastatic prostate cancer being one of them, high-risk locally advanced prostate cancer. And we know that high-risk non-metastatic hormone-sensitive prostate cancer has 3 drugs. And so some of you have seen the data on the Spartan study, for example. And in that trial, they used metastasis-free survival as a surrogate endpoint which was accepted by the regulator for licensing of these drugs. PSMA PET CT? Not there. Right? Similarly, we know that radiographic free progression is a very powerful endpoint for the licensing of a number of drugs. I mean, it's a survival endpoint is obviously the best one, right? Overall survival, I agree. But radiographic free progression is always there either as a co-primary endpoint or a secondary endpoint, both for the hormone-sensitive state as well as for castration-resistant state. So you will have seen this data that was published recently in the New England Journal, in the Lancet, where you can see how metastasis-free survival in M0 disease, so bone scan and CT defined, the endpoint was metastasis-free survival, CT and bone scan defined, translated to an overall survival, right? Level 1 evidence. So if you're going to use next generation imaging to break the bank or change the clinical paradigm, the level of evidence has to be much higher than just pretty pictures. Firstly, does next generation imaging truly reflect the metastatic disease burden, particularly if bone scans and CT scans are normal? So what is the sensitivity, for example, of PSMA PET CT in normal sized lymph nodes? It's no more than 60%. In fact, average is out about 50%. So when you see the trial by Hope, where he quotes 72%, that is for all comers. But if you take M0, it's only 50%. Specificity is high, sensitivity isn't great. So it's not reflecting the true burden of metastatic disease. Is there an unbiased impact on survival or treatment algorithms? Unbiased. Have the trials been done? No. right? Where is the predictive or prognostic value of these next generation imaging technologies? It's not there. Now, clearly there are some patients who benefit from the use of next generation imaging. Clearly. And oligometastatic disease are obviously these sorts of patients. But if you're going to play this game, you've got to play the modern game, and the modern game will include molecular diagnostics. So, is it going to add to other ways of assessing risk? You know, RB1 loss, TP53 mutations, PTEN loss, etc., etc. So, these are very important challenges. So, there's a lot of, stop, slow down. And Pete Ost was always saying, slow down here, okay? Now, can we get PSMA PET CT scans just like that? The answer is no, you have to wait. So timeliness and availability, and can it fit into the treatment pathway is an issue. There is a resistance to changing the therapy paradigm because approvals are linked to methods of assessment. And that's one of the issues. Your managers are going, I can't get paid for this, right? It's a problem, right? And you need to be paid for it. A lot of confusion amongst clinicians who really don't know, are not very clear about whether benefits will come along. And of course, there are changes in perspective of the disease because of length of time, lead time, and stage migration biases. So, it's very clear that imaging should be used, okay? You should only use next generation imaging, in my view, if you use bone scans and CT scans and then you use it to change a therapy paradigm or you change patients' prognosis. I mean, clearly, there are going to be the use of next generation imaging, but it has to be transformative. So either prognosis or management will be changed. So there's a clear, central, established role for bone scans and CT scans based on level 1 data. I've shown you some of that, generated by you, not by us, by you. So you have done it, okay? It's convenient, affordable, but we recognize limitations because there's a lot of experience. There are established workarounds. We know that's important for drug development. Reproducibility has been shown. It can be prognostic. It can be predictive. It's established in the current models. It doesn't have the biases. Of course, there are a few roles for next-generation imaging technologies, particularly oligometastatic prostate cancer using for metastasis-directed therapies. But even in those indications, it's usually after bone scans and CT scans, except perhaps in low-risk biochemical recurrence. Thank you very much for listening.